Every day, the human nervous system processes thousands of routine microstressors. In pathology, this functional processing collapses into electrical chaos. Woodworth defined this baseline emotional arousal as a stirred-up state, or a disturbance of the mind, a normal reaction to environmental demands. The Yerkes-Dodson law shows that a moderate amount of stress is required for optimal cognitive and clinical performance. Controlled arousal sharpens focus. Pathology begins at the tipping point. When adaptive arousal is overwhelmed, cognitive performance fails and clinical anxiety takes over. Diagnosing these conditions requires identifying exactly what pushes a patient's physiology over that cliff. Board exams test your ability to pinpoint exactly where functional arousal crosses into a maladaptive disorder. Evolution designed fear as a transient survival tool. Clinical anxiety occurs when that tool fires disproportionately to the threat, severely impairing daily function. Foundational psychological frameworks recognize fear as a universal baseline emotion. Tompkins, Izzard, and Plutchik all place fear at the apex of their affective continuums. In clinical nosology, this evolutionary trait splinters into three specific, testable pathological branches: general anxiety, panic, and phobia. Passing the boards requires identifying the strict, precise criteria that trigger each of these distinct branches. We can differentiate the anxiety spectrum by building a matrix based on trigger specificity. First, we isolate the trigger mechanism required for a panic disorder diagnosis. Panic disorder relies on recurrent, unexpected attacks. The physiological storm is entirely spontaneous, without an external situational trigger. This spontaneity contrasts with social phobia, which is defined by a psychosocial environment. Social phobia hinges on interpersonal judgment. The patient fears scrutiny, negative evaluation, and humiliation in social situations. Finally, we define the core environmental trigger for specific phobia. Specific phobia is stimulus-bound. The reaction is triggered only by a well-defined object, like an animal, or a specific isolated situation, such as flying. Identifying whether the trigger is spontaneous, evaluative, or stimulus-bound initiates the process of diagnostic deduction. Pinpointing the trigger is only the first step. We must also apply the temporal boundaries required for these clinical classifications. Both the ICD-11 and DSM-5 mandate a 6-month chronicity requirement for phobias and anxiety disorders. Within this 6-month window, exposure to the phobic stimulus must provoke an immediate, out-of-proportion fear response. Panic disorder is the exception. Because attacks peak rapidly, the diagnosis relies on a 1-month threshold of persistent anticipatory anxiety about future attacks. Without meeting these chronicity thresholds, an intense reaction remains an acute stress response rather than a diagnosable phobic disorder. To understand how these phobias develop, we must look beneath surface-level symptoms to the biopsychosocial etiology. Maternal anxiety, parental depression, and overprotection are the primary developmental precursors for severe separation difficulties. We see the behavioral maintenance cycle clearly in pediatric school refusal, a frequent focus in psychiatric board questions. This demonstrates the mechanism of negative reinforcement. A stressful stimulus prompts avoidance, which yields temporary relief. That immediate drop in anxiety rewards the brain, ensuring the avoidance behavior repeats and the pathology solidifies. Avoidance serves as the mechanism that converts an acute fear into a chronic, treatment-resistant trap. The psychoanalytic perspective examines how specific phobias originate within the unconscious mind. Early pioneers formulated these theories through clinical observation, focusing on how the ego manages internal stress. They define defense mechanisms as unconscious, maladaptive strategies used to cope with unacceptable internal anxiety. In phobia formation, the primary defense mechanism is displacement. The ego extracts internal conflict and maps it onto a distinct external object. Projection often operates alongside displacement, allowing the patient to externalize the threat and perceive it as coming from the environment. The phobic object is rarely the actual source of fear. It is a symbolic, avoidable target for displaced internal conflict. This behavioral cycle leads directly to our clinical management strategy. Clinical guidelines identify cognitive behavioral therapy as the first-line treatment for the phobia spectrum. CBT utilizes exposure therapy to break the negative reinforcement loop by preventing the escape response. By systematically preventing avoidance, the patient learns to tolerate the anxiety until the conditioned fear response eventually extinguishes. Effective psychiatric management dismantles the maladaptive coping mechanism, moving beyond the temporary relief of immediate distress. Here are the essential diagnostic anchors for the boards. The triggers: panic is spontaneous, social is evaluative, and specific is stimulus-bound. The rules: apply the 6-month temporal cutoff for phobias, identify displacement as the psychodynamic root, and use CBT as the primary management. To master the anxiety spectrum, clinicians must analyze the object of fear alongside the duration of symptoms and the behavioral loops used for avoidance.